Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Lokesh, gastroenterologist at Vedant Gastro Center, Bengaluru, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
I'm Dr. Lokesh, medical gastroenterologist. I'm the director of Vedanta Super Specialty Center and a lead consultant at Sparsh Hospital, Bangalore. So I'm talking about a very common topic called IBS. So the prevalence of IBS in the general population is around 20%.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
IBS is defined as irritable bowel syndrome, but sometimes the patient comes with history of patient having crampy abdominal pain with bloating and increased gastrocolic reflex, like they feel like urgency in passing stools. And some people, they come with, once they pass the stool, the pain abdomen is relieved. Some people will have diarrhea, some people will constipation. They have a very long standing history. Many people are also depressed because of these symptoms. So, in a nutshell, IBS is defined as a kind of intestinal colic or intestinal irritability.
In your experience, how does a typical IBS patient present in an OPD?
Typical IBS patient usually present to OPD with a long-standing history of chronic abdominal pain, like they will have a crampy, colicky pain in the abdomen, usually more after taking food. Some people also will have, along with the pain, they will have altered bowel movements in the form of loose stools or unformed stools. Many patients, they give a typical history like the moment they eat, they feel like passing, they should use the washroom. This is one of the important feature in IBS. At the same time, we have a other type of IBS where we have a constipation type of IBS. In them, usually the patient present with either the bloating, discomfort, and difficult to pass the stool, or sometimes they spend more time in the restroom to pass the stool. So these are the common symptoms which the IBS will present to us.
What are the top 3 red flags that make you suspect IBS in a patient?
I would like to put it in a different way. The red flags are the one which usually we assess to rule out the IBS. In the sense, the patient usually, I've already said the typical presentation, long history with pain abdomen and altered bowel movement, crampy abdominal pain. These are the common features of IBS. But if these patients have other associated history like the presence of blood in the stool, a black color stool, or weight loss, a persistent diarrhea, or sometimes the late onset symptoms that the patient present with usually after 50 years with these features, we don't label it as IBS because IBS is a benign. After 50 years, we need to consider many other diseases like IBD, Crohn's disease, or ulcerative colitis, or sometimes cancers because it's quite common after the age of 50 years. So these are the red flag signs where whenever there's a weight loss, there's a blood in stool or altered bowel movement, which is persistent even in the night. So this goes in favor of non-IBS.
What are some common mistakes in diagnosing IBS at the primary care level?
So most of the time, the primary physicians or GP level, any patient with acute gastroenteritis like IBS, as I already said, it's a very long-standing history will be there. The patient will suffer from this disease from the teenage or at least minimum 6 months history. If a patient comes with the similar complaints of altered bowel movement with loose stools or pain abdomen, bloating, they label it as IBS. Usually, short history of less than 1 month, we should not label it as IBS. Many times in India, the tropical country where the infections are quite common, they often usually have infections. First, we need to treat the infection, then we should label it as IBS. And many people also label age above 50 years as IBS patient. So the first time onset of symptom after the age of 50 years, always you should thoroughly evaluate them because these are the patient will have a some dreadful complication or say, I mean, dreadful illness in their colon. So they require a thorough evaluation like endoscopy, colonoscopy, and imaging to rule out and label it as IBS.
Once IBS is diagnosed, what is your first line approach to management?
So the first line approach in IBS is once you diagnose, so the expert's opinion is required. You need to contact the nearby gastroenterologist. So many patients usually they come with symptoms like usually the symptoms is long standing and they have a lot of psychological depression or anxiety disorder because of long standing illness. And before any doctor, they might met many other doctors because the symptoms are not relieved. And first and foremost thing is we need to reassure them and explain their about the IBS. Second point is the reassurance is this disease is not curable disease, but usually this won't affect their lifespan or this won't cause a major serious sequelae in a long run. So once you take the confidence of the patient, first thing we need to tell the lifestyle changes, regular physical activity, good sleep, and at the same time the diet plays a very important role where we need to prescribe them a soluble fiber and spacing is very important. At the same time, there's an entity called FODMAP foods that I'm going to explain, where you need to avoid certain foods which triggers the IBS. And foremost thing is the stress. Stress is a very important factor which triggers the IBS. So we need to control the stress by either physical activity or doing meditation and yoga. So this helps them to control. If these things doesn't work, we need to put them on pharmacotherapy.
How do you tailor treatment between IBS-D, IBS-C, and mixed IBS?
So the IBS is of three types. So same patient sometimes they experience both type of IBS. Sometimes they will have irritable bowel syndrome, diarrhea type, irritable bowel syndrome, constipation type. So in irritable bowel syndrome of diarrhea type, usually they will have the predominant feature is loose stools or altered bowel movements. In irritable bowel syndrome of constipation type, the patient will have abdominal pain, bloating, discomfort, and constipation. Some people will have both. They have both diarrhea type for a few days and constipation type of few days. So based on the history, once you delineate what predominant symptom the patient is suffering, we need to treat accordingly. The diarrhea type, usually we put them on some kind of antibiotic to reduce the bacterial overload so that the diarrhea will come down. At the same time, we need to supplement with the probiotics. And many times, the crampy abdominal pain will be relieved with the specific antispasmodic, which works on intestine level.
What's your opinion on the role of rifaximin in IBS-D? Where does it fit best?
So this is definitely an important thing. Like in IBS, in irritable bowel syndrome, there's an altered gut microbiota. Because of this altered gut microbiota, there is an entity called small intestine bacterial overgrowth. There will be excess of bacteria in your small intestine. This leads to excess of gas production. At the same time, they also have diarrhea, secondary to the excess of bacterial overgrowth. So the role of rifaximin usually we give for a short course of 14 days, 10 to 14 days. So where it reduces the bacterial burden, kills the bad bacteria. Once the bad bacteria is killed, we replace with the good bacteria, probiotics. So the role in IBS is any patient with bloating, any patient with diarrhea are in a post-infectious IBS. There's an entity called sometimes the patient with acute gastroenteritis, they end up with post-infectious IBS. Usually this passes for shorter duration, 6 months to 8 months. In such a condition also, the rifaximin play an important role to control the symptom as well as relieve them from the IBS.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
Okay, see the FODMAPs is the diet wise, usually you need to substitute them with as tolerated, we need to put them on, soluble fiber because fiber is very important for the normal functioning of the gut as well as body. And these are the patients, they can't ferment, they can't digest a short chain fatty acid, which are called FODMAPs. So these are the FODMAP contents are like fructose, lactose, galactose, and many other substances, polyols. So certain food products like especially the wheat, onion, dairy foods, as well as the fruits like apples, mangoes, and honey. These are the ingredients the IBS patient can't digest. When they take these products in excess quantity, they develop either abdominal pain or loose motions or sometimes the bloating or sense of increased stool urgency. So when the patient is on these products, so we need to tell them like it is not a blanket therapy. We need to tell them like first eliminate all the foods which has high food maps. So once you eliminate, you reintroduce them in a smaller quantity, and as you tolerate, so you can maintain it. So normally the triggers will be 24 to 48 hours once you take this medication, this kind of food. So you eliminate them for a week or 2 weeks and reintroduce in a small quantity. If you tolerate with a small quantity, you continue. This is what we advise our patient. So you can't avoid everything, but it should be tailored according to your body tolerance.
Do probiotics or prebiotics have a role in IBS treatment?
There is definitely a role of prebiotic and probiotic in IBS. Because in IBS, what we commonly see is altered gut microbiota. There's a change in gut microbiome because your large intestine has 100 trillion bacteria. Any stress or infections or per se IBS patient will have altered bowel movement because whenever there's a gastrointestinal motility issue, they will also have the change in the gut microbiota. So once we treat them with antibiotics, we can replace them with a probiotic. A short duration of probiotic for 15 days to 1 month will definitely help to overcome the symptoms of IBS. And natural patient also can try natural probiotics, all fermentable foods and curd and even the fermentable products like idli, dosa, all this contains a probiotic.
What advice do you give to patients for long-term gut health and relapse prevention?
So I advise my patients better to know based on food tracking what kind of food triggers your symptoms. So let them avoid those foods or at least in excess quantity. So let them avoid the especially the milk, broccoli and cabbage and excess onion and garlic in their regular diet. The second point is sleep is very important. That reduces your stress levels. So minimum 6 to 8 hours of sleep according to their nature of work they should follow. Then second point is good physical activity because physical activity releases a lot of endorphins that also harmonizes the neuronal imbalance in the gut. So that is also very important. Exercise, diet, and sleep. So these are three things I recommend, and avoid all kind of fast food and fried items. So these things will play important role to maintain the gut integrity and maintain the good gut health. And more food from the vegetable source rather than non-vegetarian source. See, what I suggest you, IBS is quite common in India as well as worldwide. 20% of the general population will have IBS. Only 10 to 15% seeks the health attention. Otherwise, most of them they maintain it as their normal regular issues. So the people who have morbid IBS patient, they should seek a medical advice from a gastroenterologist. And we have a lot of good drugs as well as maneuvers where we can control the IBS symptoms, and you will have a good quality life when you are on these medications. So please seek a medical attention when you can't manage with a regular diet. Thank you.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.